Thrombosis.TV coverage at the 2015 ISTH conference in Toronto. I'm Thomas Baldrick. This is Dr. Phil Wells from the Department of Medicine at the University of Ottawa. Thank you for coming by, sir.
Welcome, my pleasure.
So you've got some preliminary efforts in predicting major bleeding. Before we get to your work specifically, what tools are currently available as predictors?
Well, there's a number of tools that have been published but are rarely used, in fact. So there's something called the HAS-BLED tool, there's something called the hemorrhages, there's the outpatient bleeding risk index, and there's a prediction tool developed through the RIET registry. So there's these four tools, but they're rarely used, and they've been used in a different population than what we're concerned about.
Let's talk about your investigation and the purpose for doing it.
Basically, when all patients who develop a pulmonary embolism or a DVT need to be treated for 3 months. That's a given factor. It doesn't matter what your risk is for bleeding or recurrence, you've got to be treated because the recurrence risk is so high. But after 3 months in patients who had unprovoked venous thrombosis, the question is, should we continue to anticoagulate them? And the literature suggests the recurrence risk is high. So, and if you recur, you could die. So that's a serious issue. But you have to balance that off against the risk associated with continued treatment. And we don't know how to assess that risk of continued treatment, that risk being major hemorrhage.
So preliminary data, what have you found?
Well, we looked at those tools that have been published, and we found that they can predict patients who have a low risk for bleeding, but they can't predict patients who have a high risk for bleeding. And having a high risk for bleeding is really the Holy Grail. Those are the ones we want to identify. Because if you have a high risk for bleeding, the balance would suggest that you should not continue on anticoagulation because the treatment is as harmful as the benefit it produces. And these tools did not accurately detect a group or did not detect many patients who have a high risk for bleeding. So that's a serious limitation of the tools that exist today.
Okay, so your major analysis is still to come. Can you tell us about that?
Right, so our major purpose of the study was actually to develop a prediction rule. So we've now, by the time we're finished, we should have about 11,000 patient years of observation of our patients and around 120 major bleeds. So we should have enough to develop a predictive tool that will look at clinical variables, genetic variables, some lab variables, and enable us to try and draw a prediction rule out. And now that I know these other models don't predict a high-risk group, we will have to tailor our analysis to see if we can detect a high-risk bleeding group. There's no need to detect a low-risk group. These other tools accurately do that. So that will be what we focus on, to try and develop a tool that predicts high risk for bleeding.
And when can we look for that?
Hopefully in the next year. The study will be completely closed, data closed at the end of August. Then there'll be data cleaning, data analysis, and so forth. And so hopefully within a year from today, we'll have published something that will give us that answer.
Very good. Thank you, sir. Nice to talk to the real Dr. Phil.
My pleasure.
You got it.